Hi, everyone. Welcome. Thank you so much for coming. I'm June Gordon. I'm an EM intensivist like the rest of us. I split my time between the MICU and then our EDICU at Stanford. And thank you so much for coming. Fred is going to help me moderate. Fred, do you want to introduce yourself, and then we'll have the speakers introduce themselves?
Hi, how are you? My name is Fred Gilmore. I'm a first-year critical care fellow at University of Pennsylvania. And we have a great set of panel speakers today to help us all. Certainly, I think we're all at different points in our career, but to help navigate the path that could be the wonders and confusion of emergency medicine critical care.
All right, should we just go through our panelists? Lillian, do you want to introduce yourself? Start with what your current practice looks like, where you did fellowship, and anything else you want to say. Sound good?
Hi, so I'm Lily Yumlett. I'm the Associate Program Director for the IMCCM portion of the Multidisciplinary Critical Care Training Program in Pittsburgh. I did obviously the training program here in Pittsburgh before it was an accredited program. We obviously followed the IM sort of pathway, and that's sort of our main certification pathway for all of our trainees is through the IM track. I'm also the co-director for the VA Interprofessional Simulation Fellowship. And I do 100% critical care, obviously 80% clinical, 20% admin, education, simulation, and I moonlight one shift a month in the emergency department, still out in the community by myself as a night doctor.
Thank you so much, and thank you so much for coming. We're very lucky to have you. Skylar, you want to go next?
Sure. Yeah. Thanks for having me. I'm Skylar Lentz. I'm the chair of the critical care section, and I work as an emergency physician and intensivist at the University of Vermont. I split my time between the ED and the medical ICU. Right now, I'm 60% clinical in the ED and 40% clinical in the medical ICU. And in the MICU here, we take care of cardiac patients and neuro patients. So it's nice to have a little bit of both. For fellowship, I did internal medicine critical care at Dartmouth-Hitchcock. I really liked the fellowship because it was multidisciplinary, but I'm boarded under internal medicine critical care. And as you'll see from our panelists, there's multiple ways to get to critical care, and mine was just one of them.
Thank you, Skylar. Andrew, you want to introduce yourself?
Hi, my name is Andrew Phillips, also emergency medicine and intensivist, and I've had the duties of sort of working both academic and community. I was at UNC a faculty there in the CVICU and working in the ED, and then I went back to the community recently, and so I'm only doing critical care during the pandemic because there were lots of opportunities for business there, but during the transition, I've not been in the ED, but that's going to be changing soon. And my fellowship was at Stanford, along with my residency as well. I did the anesthesia critical care path. I think that's what you asked for us.
That is, thank you. And David, how about you?
Hey, I'm David Gordon. Thanks for having me. I'm an EM soon-to-be intensivist in like a month and 5 or 6 days or something. I'll be finishing up my fellowship in critical care medicine at University of Maryland. So I spent the last 2 years primarily in the different units here. I did my residency here in Maryland in emergency medicine and did my fellowship in critical care medicine. Also here at University of Maryland, in between the two, I did a resuscitation year at Stony Brook in their ED. Thanks for having me.
Thanks for being here. Dan, is that you on the phone?
Yeah, it's Hathi. I'm here if you guys can hear me. Sorry, I'm having some, it won't let me join via Zoom, only call in. So I'm having a couple issues, but I'm here.
I'm so sorry, but thank you so much for being here. And even having you on the phone is excellent. So Fred is tech savvier than I, and he's working on your invite issues. But if you don't mind on the phone for now, introducing yourself, your current practice, and then what fellowship path you did, if any.
Yeah, okay. So my current practice, I'm currently the medical director of the CCRU at Shock Trauma at University of Maryland. So, and then split time with a little bit of trauma ICU and our VV ECMO unit. So I'm pretty much all critical care or our version of an ED ICU. moonlight a little bit in the emergency department when I get free time, which isn't that frequently. And then my career path is one of the more interesting ones. So I trained way back when emergency physicians couldn't get boarded in surgical critical care. So I did 1 year surgical critical care at shock trauma. And then Dr. Emlet was nice enough to let me do a year at Pitt. So I have 1 year surgical critical care, 1 year critical care medicine, and boarded in critical care medicine, and then we'll actually grandfather into surgical critical care this year. So I'm kind of a dual training, dual board certification person.
Awesome. We're so happy to have you. Thank you for coming. So I think I'll put the first question out to all of our panelists, which is, what do you wish you had known then about your pathway? So the fellowship pathway that you chose, job choices, it's purposefully vague. And anyone can answer.
I think I can start with this as someone maybe who just is kind of going through it now. And maybe people who are a little further along in their career will have a different perspective, which would be awesome to hear. I think what I wish I had known is that I should start at the end with what I want things to look like, and then map backwards instead of kind of starting from where I was and trying to wind my way forward. Obviously, as you move forward, you're going to find things you're more excited about and less excited about. And I can't say that when I left residency, I thought I would be doing a critical care fellowship. Certainly, Dr. Hasse and I talked a lot about it when I was at, before I went and did my recess fellowship. But I think if you start at the end, that will give you a much better idea about what things you should do as you go through EM and go through fellowship, and you plan what route you take to help you choose what to do. So starting at the end and working your way backwards would probably be a really helpful step that I wish I would have taken.
So I guess I'll speak up as the best laid plans of mice and men, kind of. So, I thought academics is going to be my gig, and I spent a lot of time. I still love CVICU stuff, doing the ECMO and such. But then other things in my life took off. I do, so you guys know, EM coach, and balancing the two just didn't work with a full faculty, full-time academic gig. And so I found the community setting much more malleable to another turn in my life that things took. And so I do my 7 days in the community, and the rest of my time, I should say days, I wish, 7 nights in the community. And then I do, the rest of the stuff that I have going on with the coach and such. And so as much as I had prepared for the academic side and doing all the papers and had, everything lined up the way it was supposed to go, life threw me a curveball. And I will add, and it's going to vary. I know one of the questions is, what if I do medicine fellowship? What if I do anesthesia? What if, all these different approaches? At least my experience with the anesthesia route, sort of accidental as it was, has served me well because it gave flexibility. The surgeons were seeming to be more open to me being in their unit, coming from that background. That said, the reason I did it was because the anesthesia deadline was first. So I figured if no one wanted me in anesthesia, maybe someone would take me in medicine. I don't know if that's helpful, but.
I think I'll just add to what Andrew said. I think that's an important point. The deadlines for applications to these various fellowships have different times, and that can make it kind of confusing for the applicant. I did similar. The anesthesia pathway, so I did a 3-year residency at UNC, and it was in the middle of my second year roughly that I started applying to fellowships. So very early on, halfway through your training, you already have to start thinking about this. So I had an application all together for anesthesia critical care programs. I applied, I interviewed at several, and I interviewed at Dartmouth Hitchcock, which was outside the match around the same time, just because their timeline was similar. With the intention of saying, well, if I get offered a spot in the anesthesia programs, I might take that instead of waiting and reapplying. But it just so happened I got offered a spot outside the match. So I think, it's getting better, I think, to my knowledge, but it's very challenging because of all the different pathways, the different timelines and the different specifications for each pathway. I don't know if Dr. Emlich can talk more to that about the different requirements and the different timelines, but I was lucky again to find a spot outside the match. So I would say, work your connections as you can, check out all the different programs you might be interested in and see what's out there. And as far as my career, I'd say it's continuously evolving. I'm trying to figure out what the right amount of critical care, what the right amount of emergency medicine, what the right amount of administration and research and teaching is in my career. So be open-minded and see how it evolves for you.
Probably second Skylar's, but I think it's also a philosophical difference, right? Some people are of the make your 5-year goal, work your way yourself backwards, and for the other 50% of us, it's actually we'll see where the winds take you. So I think if I had known what I had known, didn't know then when I first applied into critical care. I mean, I only applied to one program, and it was Pittsburgh, mainly because of who it represented. It was either Pittsburgh or shock trauma. There were only 2 really places in town back then. If I had known that we would have created certification pathways that would continue to silo critical care delivery, I guess I have to admit, I'm hopeful that maybe in this next generation, that all of you and also all the people who are listening to actually push for something a little bit different for multidisciplinary groups to actually sort of unify the hospital's desires, because it actually does align better with healthcare systems, employer-based sort of mindset to have multi-specialty groups that actually are supposed to feed off of each other rather than leaving these silos of pathways. If I could say 15 years later, this is what we would have. I mean, I think it's pretty awesome. It's pretty amazing. There were 30 people in a ballroom at ASAP section, with like a piece of paper that we would sign up to help out, right? When I was a PGY2, I guess, in Boston, Boston's ASAP. And now we're like, what, 600, 700, 800. We have new speakers, rising stars all the time. We tweet about each other, we publish, people are chairs now, full professors in different institutions. It's pretty amazing how far we've come in 15 years. I don't think I would have imagined how far we've come already so far in such a short period of time.
Awesome. Great responses, everybody. The next question that we have, and to comment on the piggybacking, I think that Dr. Haas is going to comment on it, but at least for per ABEM this year, I think it's up to 265 or so ABEM accredited, and then with 35 surgical critical care. So it's definitely a crazy expanding field. And I think this year is going to change when more people are grandfathered in, which will be great. But what advice do you guys have to kind of both people at med students, residents, and even fellow levels on things that you wish you would have known even a few years back on career goals or projects to work on or how to get best involved?
I'll start with that. Sorry, it's casual Tuesday or whatever day it is. I'm on vacation out in Denver, so I'm out in a field after I went hiking. So sorry, you still can vacation even when you're attending. I think the advice that I'd give people is try to figure out it's very hard to figure out what kind of patient population you want to work with. I think that it's still very, there are still limitations for the EM people in academic medical centers, in geographic instances, and trying to figure out what type of patient population you want to work with and what type of practice you want to have in the future is really going to help determine which place you want to go to. I think that it's challenging to do that, and I respect that, but I think that can really set you up for success. I know that fellows who choose a certain pathway may be a little bit hamstrung by which pathway they go to later on, but if the sooner you can figure out like what type of path or what type of patients you want to treat in the future, so it's spending elective time in a surgical ICU, spending elective time in a cardiothoracic ICU or on ECMO units, because that is particularly popular, especially later on. Get exposure as much as you can early on to try to figure out where you want to go, because that'll be really determinative of what fellowships you want to choose or which pathway you want to choose.
Yeah, I would add, I think getting involved with things like this is great too, because you get to know many of us and At least I'm, open to emails and different things. But our group in general, the section of critical care here, is very open to having you all join our monthly meetings, meet us, talk to us. It's funny, before, as we were setting up for this and talking in the background, all of our jobs look different. So I think finding mentorship is so important. So you get a realistic idea of what this practice looks like and what your options are, because we're still trying to figure out what emergency medicine critical care looks like. And at each institution, it tends to be different. We also have a mentorship program set up just for this reason, so that you can get paired with somebody early on. And however formal or informal, I would recommend seeking out mentorship in people who have done it, people at your own institution, at your med school, just so you can get started early and see what you have to do to be set up for success.
I want to take a spin on the mentorship part and say, no one has one mentor. There's no one. I think a common misconception is, oh yeah, I'm looking for that right person who does exactly what I want to do. Especially if you're an EM intensivist, there ain't anybody else who took the exact same route you did and does the exact same thing that you did. So find multiple mentors, and there's nothing wrong with taking a crack at a project here, a project there, rotating on a different unit, use their lifetime. But the other thing is that there's still the concept of, and I guess I'll say this, this was only 4 or 5 years ago now, when I was first interviewing for gigs. And there were 2 locations. These are, big name centers, you would recognize them, who it was pretty obvious I was invited to interview only because they were wondering what the heck an EM intensivist was. Like, what is this thing that they've heard about, and who are these people? So, sometimes, they're not going to be as many opportunities in some locations. And so, matching the opportunity with whatever your research gig may be, interest may be, with wherever the location you want to live is going to be, with the particular type of medicine you want to practice, trying to find that exact perfect match is very unlikely. So, being open to what areas are of interest to you. And granted, we're all emergency medicine physicians, so we like a little bit of everything. But take it with a grain of salt. And I encourage folks to, just like going to med school, when they try to discourage you from going in knowing you're going to be an orthopedic surgeon from day one or whatever, right? Kind of go into this, I would offer, at least from my experience, with an open mind of where you're going to wind up. Because, as I mentioned, I was in the CVICU and I love it. I still love the ECMO stuff. And yet, I didn't have grandma pneumonia, and I didn't have, the strokes, and I didn't have all that, well, except as complications of the LVADs, but that's a whole nother story, right? So like the general stuff, the bread and butter that comes in from the community stuff is interesting as well. So be open to maybe adjusting your expectations with a combination of lifestyle, location, mentorship, research agenda, and practice of medicine, from my perspective anyway.
Can I ask a follow-up question to that lovely topic you guys brought up? What is your advice to especially our med students, residents, on how to be a good mentee? What should they bring to the relationship to make it a really fruitful and meaningful relationship?
Yeah, I think one thing is going to be transparency, right? Like, some people know exactly what they want. They know exactly where they're going to fit under education, clinical admin, QI, research, and they also know where they want to dabble. And so have a time-limited trial of clinical care, a time-limited trial of dabbling. See whether you can figure out in a year whether you want to sort of go in one direction, try it out, and go full-heartedly into that particular arena. And then when it doesn't fit, it's fine. Don't worry about it. It will still serve you well. I think all of us have had different hats, either in trying to do research in whatever domain that we've been in, clinical leadership, education projects, and as it sort of falls out every 5 years or so, right? And the nice things that you can do a pivot. I think in terms of combining with the last question, you have to embrace your inner unicorn. Every single one of us is a very special creature in the house of medicine, and you have to be okay with that. So I think the hardest thing I find with students and residents right now who don't understand our history and have not embraced their inner unicorn, it is perfectly awesome to like different things, to be unapologetic about your board of director of mentorship, and also figure out that every couple of years I might pivot, and you don't have to apologize for it. At the same time, take that board of directors sort of guidance. Is like, if you're going to do it, you got to do it for a little while. And so if someone says you're going to do research, you can't be doing these other things, then don't do those other things. So you also have to sort of understand the other perspective from people who are in medicine, anesthesia, or surgery, the other big chairs in your academic institutions. They just have a different perspective. So learn from them, try it out for a couple of years. And then when it's time to pivot and go back to your EM and CCM sort of roots, then go ahead and do that. So it's helpful to be okay with focus and yet also diffusion of your interests.
Sorry.
A question
I
that just.
one
Sorry, go
one
ahead.
thing about mentorship, but your mentors don't have to be where you work. Your mentors don't have to be where you did school or fellowship or whatever. I have a few mentors who aren't even on this continent. You meet them at meetings, right? You meet them on papers. If you find someone who did a paper, and I realize there's a big academic stint to this, right? I have a mentor only because I read some of their papers and saw I was doing similar stuff and just totally cold emailed this person. I was like, hey, I would love to talk with you. You sound like an interesting person, and we do the same research. And then that led to mentorship. This person's over in Scotland. Go figure, right? Like, so they don't have to be anywhere near you. It's also people are honored to be asked for their advice. So reach out beyond local. Sorry.
That would be a perfect jump in. This actually, I think, will be right in your wheelhouse. Derek Salute actually, as a follow-up, asked, are EM trained critical care physicians able to manage ECMO patients? So I know everybody on this group will likely have good opinions about that.
I won't be offended that you asked. Yes.
I'll start with that. So yes, the answer is yes, but I think you have to position yourself to go to a program or go to a pathway that allows you to get that training. Like, not every place in the country does that, right? Like, so you have to be intentional about that, and different pathways at different places will give you different experiences. And so yes, I think that's actually maybe it's not the right time to talk about this, but I think one of the huge opportunities for EM critical care in particular is in cardiothoracic ICUs or cardiac surgery ICUs. There's a paucity of intensivists in those places because the surgeons don't rotate in those places, and we can do that. We just have to be smart about the places that you're going to go do that stuff. So I think this goes back to positioning yourself well to go to a place that does that, gives you high exposure to CSICUs. I know that there's a few places in the country now that are offering ECLS or ECMO fellowships, my place being one of them. But I think that absolutely you can. You just can't go to a place that doesn't do those things. I think you have to be very, if you think you want to do that now, start thinking about which places are going to offer that, because it's very geographically dependent.
I'll jump in here, having gone through my job search recently. I probably have 5 or so months between my recess fellowship and just in my critical care fellowship, at least of managing ECMO patients. And I work in moonlight in several of the units where we manage the ECMO patients. And in my job search, for the most part, every place was interested and encouraged me to pursue working there and doing ECMO there. I mean, for the job that I have next year, the head of ECMO just said, hey, you want to do ECMO? That's great. We're building a program. We'd love to have you. I really want to, you're in. So people want to teach you, and people, I think, want to learn. And I think people know that we know how to do that stuff and know how to get along with people.
I have a follow-up question for you, David. Why did you go back after your recess fellowship? So sort of a two-part question. 1, why did you do a recess fellowship? And 2, why'd you do another? And maybe you can tell our attendees a little bit about the difference in the fellowships if they don't know the options.
I see Hasi laughing because he and I talked a lot about this. So I was really lucky speaking of mentorship, in my second year of residency, to really come across a great mentor, and to have a bunch of other great mentors at Maryland who got me really interested in pursuing critically ill patients. And I actually didn't love my MICU time as an intern at Maryland. And I said, gee, I really don't think I want to work in an ICU, but I really love taking care of sick patients. And so one of my mentors was very open and pretty instrumental in pushing me to pursue a resuscitation fellowship. And I did, and it was great. And I got a lot of opportunity to manage critically ill patients in the ED. And I thought that was a really great opportunity. Ultimately, as I spent more time, that was kind of during my second year, as I spent more time later in my fellowship, I said, oh, I'm kind of liking some of the ICU stuff, was one thing. And then the other thing that I noticed was, I said, I really don't want people to be able to tell me I can't do something because I'm not critically care ported. I didn't want the walls to be up in the very siloed way that we practice medicine, at least at Maryland. I can't speak for everywhere, where just because I haven't done a critical care fellowship doesn't mean I can't do certain things, like managing ECMO patients, like pursuing that, like managing those things and taking on those procedures. And so all those things kind of pushed me to pursue a critical care fellowship. And I can tell you, having, I think, worked both in the ED and as a critical care fellow at Maryland, I think the response to you walking into a unit or dealing with people as a critical care trainee is a lot different than you walking into a unit and people's response to you as an EM trainee. So for instance, this month I'm in the cath lab. I'm doing a lot of cool cath lab stuff. I don't know that I would have gotten that opportunity or would have the same response in the cath lab as I would had I come in as an EM trainee. And to me, it just opens more doors to do that. I think the question you really have to ask yourself in terms of deciding if you want to pursue a resuscitation fellowship, I can tell you all of my co-fellows who did recess fellowships have super cool jobs where they're managing or critically ill patients in their EDs, and they're in charge of working up and building their critical care sections of their different EDs. If you want to do that, that's one thing. If you want to work upstairs, if you want to take care of those critically ill patients 2-3 days down the line, if you really want to understand what that looks like and you want to not have those walls in terms of your practice, I think you have to do a critical care fellowship. And that's kind of the decision that you have to make if you want to stay downstairs or you also want to have those opportunities upstairs. Does that answer your question?
Perfect. Thank you.
Great answers. And I think this question jumps right into certainly something that I wonder about as David, as I approach hopefully being in your shoes and being employed soon. How do you go about negotiating that first contract? And for a lot of us EM folks who want to actually seek dual appointments rather than 100% one way, how do you negotiate those first contracts and not end up with two bosses who want 100% of your time and 100% of meetings and 100% of productivity while still somehow existing?
I might be able to speak to that. I'm about 3 years out of training, so I navigated this not too long ago. So my tact on it was I applied through emergency medicine because I kind of figured those are the people that'll want me the most because of my fellowship training. I'm more special to an EM group, especially a new residency, as is the case here at the University of Vermont. We've started a new emergency medicine residency. So I knew that my training would be of very high interest to the emergency medicine group. And then they were in turn able to reach out to the critical care colleagues here in the division and in the Department of Medicine. And I was able to get a foot in the door in the MICU. I started out with less time than I wanted. I started out with 25% time of my clinical time in the ICU. And I just from day one just said I'd like more than that eventually. And after a year, I now have much more time in the intensive care unit. So I think, at the beginning, you at least get part of what you want and get that built into your contract. I think where people can go wrong is, maybe promises are made, but if it's not sort of in your contract or if it's not, present from day one, I think you have to be a little bit careful because it's hard. This is challenging to have a dual appointment. It's challenging for the institutions to do it. So, my best advice is to get some of what you want from the get-go. It may not be exactly what you want, but you at least need a foot in the door, and then you can work on expanding that in the future. June, I'm going to put you on the spot too. I know you just got a job too, so I'm sure that you have some advice here as well.
Totally, thank you. I was the moderator, so I didn't have to answer these questions, but so I have a similar situation actually. So I'm hired through the emergency department and lucky to have, sort of one department, one boss, which makes it easier. But I will say for me, and I think other people, my co-fellows, it's really the ICU time that is the challenge. So while you are special to the emergency department, it's really the ICU time that is the scarce resource. And so when you think about jobs and you think about the split you want, just keep that in mind.
So having, again, just gone through the job search, I want to share with you guys a little bit of what I've found out there in the world as I was searching. So my job next year, I'm hired 100% through the emergency department, but that's an emergency department that has an ICU contract with a community ICU and also some kind of other shift work with the academic ICUs. And I found a similar setup of the academic ED has a community ICU contract at a couple different places. And so I think that's one way to, at least that's the setup that I think is starting to exist. And I saw that, like I said, a few places. The other piece of advice that I got was always be hired through one department. So you have one boss and have like a home, and like that's your home. And those are your people, and that's who you have that's who your primary boss is. So you can go to them when you have any issues. And I heard that repeatedly across like every interview, every person, everyone told me that. And so I think that's a really consistent piece of advice to kind of keep an eye on. And the other piece of advice that I got that I think was really good was don't go someplace where you're the first one, especially right out of fellowship. Don't go someplace where you're the first one to do something. I don't know if that's going to be a piece of advice that everyone else says. I got that from kind of a cautious mentor. But if you go where you're the first one to do something, then everyone's going to be working to try to figure out like, what do you do and who owns you and stuff like that, instead of just going and being built into a thing and being able to build your sense of how you practice medicine.
So I guess I'll counter that. Everyone here on this call has been a first, and everyone else who's listening to us is going to be a first. And so we're going to need everyone to continue to fight the battle that we've all fought for 20, 50, 60 years. And so I don't think that makes you shy away. What I tell my fellows is the fact it depends on where you see what's most important to you. If academic promotion and the power of the Department of Emergency Medicine academically is strong, so for example, in Pittsburgh, emergency medicine is very strong. They have a lot of great promotion pathways. They reward their clinicians, they reward their educators, they reward their researchers for promotion. I actually advise them to go in the Department of Emergency Medicine, mainly because if their portfolio matches that department's interests. If your interest actually matches the Department of Anesthesia's portfolio, then you should go with the Department of Anesthesia. And so you'll find that many of us actually have primary appointments in departments of surgery, anesthesia, and medicine. And it isn't because we didn't necessarily want to be with emergency medicine, but for example, even in Pittsburgh, it's pretty clear that the chair would like me to be 51% at least primary emergency medicine, giving all of my research or education to direct learners of emergency medicine. And if it's not that, because obviously my learners are multi-specialty or other disciplines, then I cannot be in his department. And so I think you have to understand that who has the power and what's most important to you. Is it just having the job? Is it having the locale? Or is it actually having the bigger buy-in at the CMO level, right? So I guess the other question to you is, do you intend to stay clinical administrative within the healthcare system? And if so, then you actually may want to go with whoever actually has more power. And if it be surgery, then go with surgery. So I think it depends on what you see as your career goals and also who has political power. Now, you don't know that when you're applying, you're just looking around for jobs. So I think rather than seeing as a detriment, we're actually super lucky. So people in medicine and surgery do not have it so lucky. They are stuck with one department to interview with. We actually can interview with anyone and everybody, and we do. And that's how we have infiltrated. And so rather seeing it as an Achilles heel is actually a powerful thing to be able to say, I can fit whatever mold or niche you want. You just have to be willing to work with me to get me what I want. And what I want is 75% critical care time within 3 years. The hard thing, I think, is for many of us, within 2 years, it's definitely, they give you the song and dance before so they can hire you. And then if it doesn't materialize, and you're left making a hard decision. So I think you also have to be prepared. The even very prestigious institutions may not deliver on their promise in like the 3 to 5 year window for your academic promotion. And they actually have a vested interest, because in their stats, they should have a certain percentage of people they're putting up and successfully getting up there. And if they don't, then that's a lose for them. And so it's a lose-lose. So hopefully they're transparent with you as much as you are with them.
I would add too that it's not just, particularly if you're going to a unit, a lot of units have folks from mixed primary specialties. So in my unit, when I was in CVICU, there was a guy from medicine and did a cardiology fellowship and did critical care. There were 2 surgeons. There were 3 anesthesiologists. There was me from the ED. So there wasn't even a question. Like, obviously, everybody was hired through their own department because that's the way the whole unit was. So I would offer, maybe don't fret over it too much, because depending on where you're looking, it's may not even be an issue.
I think one of the pieces of advice I have about splitting time is that you always want to not just split percentage of time, but split calendar time. So my advice to everybody is, if you want to split 50-50, all the odd months are emergency medicine, all the even months are critical care. That's when they own you. But this kind of overlapping time is very difficult. I manage 9 EM critical care faculty at Maryland, and everybody who has split time, it is very clear of like the first 2 weeks of every other month is their EM time. Every other time I have them. And so managing calendar time really helps piece out like when you belong to emergency medicine, when you belong to critical care. And I think that's been one of the things that has been very satisfying, so that we're not picking each other's time and people aren't double booked. And that's been one thing that's been particularly successful in our group.
I may need to take that advice myself. I feel double booked often. But I'm the only one that does it at my institution. I'm the only one that splits time. So it's part of this figuring it out. And I'm still figuring it out myself, and my institution is too. But I think there is power in it, or there's strength in it, in that I can choose mentors from both departments, the Department of Medicine and Emergency Medicine. And we have very strong researchers in medicine, and they've been my mentors on projects. Whereas in emergency medicine, we don't have strong mentorship and research and different things. So it's nice to be able to pick and choose your mentors and friends from different departments and use their strengths to your benefit.
Sort of jumping into the response to this question, in big academic centers, where do you guys see the future of having a department of critical care opposed to silo houses of individual critical care? Because I know there's a lot of people trying to put together white papers certainly on departments of critical care in big academic centers.
I mean, I think it's coming. I think, each place, as they get more and more multidisciplinary, realizes that it's very hard to coordinate 8 different ICUs that all have a very subspecialized focus without having a more cohesive department or division, or Maryland's leaning towards a program. But I think having a centralized spot is going to happen. Not everyone is that lucky, but I do think that there's some benefit in having those multiple departments. But I think it's coming in a lot of places. It's going to be slow, but I think it's getting there. I'm not sure that there's a huge disadvantage other than kind of just the siloed nature of what an FTE looks like, what pay structure looks like across different ICUs. I do think there's a lot of disparities amongst a lot of those things still, and I think departments can really help those things. But I don't think it would dissuade me from taking a job at a place that doesn't have a department or a strong program in critical care. I think that it's just something that is going to happen and probably should in the future, but it shouldn't be a major contributing factor as to whether or not you choose critical care or where you choose to go.
At Maryland, we've actually, I think, for at least my 2 years in fellowship, we've been having a lot of this discussion, which is, like, we all kind of follow our patients into the ICUs as far as our ICU track, and that kind of leaves EM in a little bit of a weird place. But we're actually combining. In some ways, COVID has been really good for this, because what's happened is we now have like a weekly email that goes out with all of the different lectures for all of our different critical care programs. We have something like 6 critical care programs here. And we just had our year-end meeting with our fellowship director, and we're coming up with like a combined curriculum for all of the ICU fellows at Maryland for like some of the critical care stuff and a lot of the unified programs in the area. And so I think we're seeing a lot of things heading in that direction in terms of how we think about ourselves in critical care, at least in the discussions that we're having with our program director here.
Yeah, I would love to see it. Where I trained, it was much more. There was a lot of the curriculum was the same. If you were in anesthesia, emergency medicine, there's very similar curriculum, and I really enjoyed that about where I trained. And when I was the on-call fellow, I covered the SICU, I covered the MICU, I covered the entire house of the ICUs, and I really enjoyed that. Where I work, it's not that way. Medicine, surgery, and anesthesia run different ICUs on different floors, and it always seems silly to me. I'm in-house and attending intensivist. I could run down and cover the SICU if they need me to, but it's just not that way, just because of the silos you all are referring to. So I think for many reasons, general critical care kind of getting together in the future would be fantastic, but I think it'll take time, but I would welcome it. And I think that comes from our emergency medicine background. We're kind of that way. We interact with every department in the hospital, and we're happy to do so. We get along with people.
I'm going to represent the community and say we're already combined, so welcome to the club.
That's the perfect segue into the next question, which was submitted from one of our attendees. Is it true that in the community it doesn't matter? So you can be boarded under medicine, surgery, anesthesia, and no one cares. So if you want a community job, does it not matter?
So that's been a topic of great discussion amongst this section and the council. And Skylar and Judy, last year we had several of these conversations, and it seems to vary by location. So my experience was that they don't care. As long as your patients are tucked away, your sign-outs are good, and you don't leave things for other people to do, and you're boarded in something, no one cares, right? They just want to get the job done. There's not the pedigree and the location that, in some places the MICU is Palm Crit. No one but Palm Crit does the MICU at XYZ Academic Center, right? So alternatively, though, one of our recent council members was actually went back and did a second fellowship because his community hospital refused to give full compensation as a boarded intensivist because he was surgical boarded as opposed to internal medicine, and the internal medicine boards are specific, or they by themselves are a specific ABMS fellowship designation as opposed to being a sub designation from anesthesia, for example. And I know, Lily, we had talked a little about this because I had forwarded you his question trying to sort things through him. But I think the short answer is depends on your community site. I'm curious what you guys have to say too. Or not.
The only thing I'll add is that some places, the ICU group may be a Palm Crit group. And if they have a Palm Crit group, then they may want you to cover Palm. And if you're not Palm boarded, you either may not feel comfortable covering Palm, but can't cover Palm. And so I had at least one place where I looked where we couldn't find a job that overlapped with my interest to work in their ICU and their need to have someone that also covered palm. And I know that that's the case at least one other place. And so in some places that have not maybe moved away from that or not yet moved to this more general ICU type thing that we talked about, the MICU may still want you to be palm boarded because that's how their group works.
Let's ask the reverse question then, which is, if you think you want an academic job, is there a pathway that makes that easier?
You mean to say IM, neurosurgery, anesthesia?
The specific question that was submitted was anesthesia versus medicine versus surgery, but I think there's no reason that it couldn't be neuro or otherwise.
No, academia is its own bizarre land, as any of us will attest to, that has its own tribal ways in terms of the institutions of each state's universities, rules and regulations, and politics of what counts as and not counts for correct service and back, I guess, dues and tithes to be able to actually have that title, of which you see nothing of really when you're getting hired. You just like, I just want to work here. I just want to work here and I actually do good work. And so I just want to contribute to the science of dissemination of something. But on the back end, from the chair's perspectives, there's costs, there's dean's taxes, there's administrative costs to actually have people on the academic faculty as compared to the clinical faculty, for example, right? You may have seen like to some degree, there's even some tiering of the titles that people get in academia. I don't think there's any difference. It's going to matter on your mentorship and how much you really want to do all of those things. You know, all of us who are in academics really like all of these secondary, uncompensated duties that we have to give to the next generation, I suppose. We understand that to get the quaternary care high, you know, to be able to be at the receiving hospitals for certain regions and to be parts of training, that it's the cost of business to some degree, that we'll have a pay salary decrease comparatively to our community colleagues, that we may not have as great work-life balance in terms of boundaries, because we all do work. You know, when my friends ask me like, oh, so are you off? It's like, no, I have 80,000 like annoying writing things that I signed myself up for. So I don't know who to blame. It's myself. We like that stuff, actually. So I think at the end of the day, academia doesn't matter, like what track you're in. It's going to depend on your mentors prepping you well, sponsoring you well, and getting you prepared and networked properly at national organizations and national networks.
That's probably a nice lead in for the next question in the chat, which is, can you still have a work-life balance?
I don't know, maybe as the person who's doing a national panel on vacation, I mean, yeah, absolutely you can, but I think you need to know, you know, it's really important in your early career to, I think some of the mentorship stuff was spoken about before, to take advantage of the opportunities that you have and take advantage in the early years of your career when you have opportunities given to you, especially in people who are not necessarily, they might be of different specialty, right? And I think somebody hit on this earlier. A lot of my mentors are not only from emergency medicine, critical care, but I have a surgical mentor and a kind of internal medicine, critical care mentor in taking care of those things. But yes, eventually you can get to that balance. And I think that you can, but you know, academics is academics. It's no different than being in a different specialty and being an academic. It is demanding. But you know, we think that there's something special about being an academic that allows us to push forward, cutting edge clinical care, research, education, and those are the reasons that you choose to do it. And yeah, you're not going to work the same schedule as somebody in the community a lot of the time. And, you know, that's what the sacrifice is for academics. And, you know, but yes, you can still find a balance. It's just a little bit different balance than you might have in the community. Yeah.
I think a question that a lot of people have been commenting on is the ACEP and AAEM and everybody's combined task force about EM job saturation. So somebody asked, and I've been seeing a lot of traction with this, especially, are you able to comment on this kind of safer pathways of fellowship and fellowships in general, and the best way to obtain an EM related job now that there seems to be kind of a mass panic about EM jobs in the next 20 years?
I guess, I mean, I listen to all of the panels, and I don't disagree. There is some degree of mass panic regarding the curve, like how many more thousand surplus are we going to have? At the same time, I have to admit, while fellowships, the 23 fellowships you can go into after emergency medicine, if you want to do them, you should do them. I don't know that they should be a definite guarantee to think that that's going to help your job search in general. I don't know that any particular alternative solution. So for example, let's say you choose clinical administration, let's say you choose QI, let's say you choose simulation, let's say you choose any of the other multiple, including critical care. Obviously, I think the only reason why you want to do critical care fellowships, you should only want to do this if 50% of your heart is that you're a longitudinal chess game player of intensive care medicine or surgical critical care medicine. I mean, right, you're only doing it because you actually like the other hat you wear. When I'm in the ED, I like being the ED hat, right? So they're just two totally different practices. You like to do both, and you can't imagine that longitudinal comprehensive care, and also you can't imagine just being able to treat and street as well. So same thing with all those different fellowships. It can help potentially, I think, with the job saturation issues. At the same time, who's going to pay for the other part of your job? They're not going to pay you at a clinical compensation rate. You won't make as much money comparatively. So I think at the end of the day, you should, again, only do those things if you like to do them. If you actually do like administration, then you, of course, should get an MBA and do administrative fellowships and actually try to become the CMO. Maybe you'll change things for healthcare in general, which I do think we all should do. All EM, especially EM, IM, CCM, should all become CMOs, because they would have a greater sense of the way healthcare needs to be delivered and all of the factors. But I think at the end of the day, you're already in the track. You're pretty far into the track already of doing emergency medicine. You just have to keep on plotting and finding your niche and advocating and trying to be creative, and also understanding there may be some salary differences and time differences compared to what it is now for some of us who are grateful that we have what we have right now and aren't facing the same worries that you have. I don't want to minimize them. At the same time, you're in a great specialty. I think things will change. We don't know that, and I think the bigger thing is that we don't keep feeding the problem. I think that's the biggest thing. Because as long as we don't keep feeding the problem, most likely there will be some place somewhere. Pandemics aren't going to go away. Emergencies aren't going to go away. Critical illness isn't going to go away. So you will be needed somewhere. The question will be, what other things do you like that will help balance things out?
So I actually think there will be an exodus towards a lot of fellowships, and fellowships allow you to do something else. A lot of people going into emergency medicine enjoy the critically ill patient, and I anticipate that we're going to see in the next 10 years a rapid growth in the number of emergency physician intensivists, and whether that's the right direction or wrong direction, I anticipate that is going to happen. On the community side, those are the EM jobs that are being gobbled up by USACs or Team Health, and physician FTEs are being replaced for alternative staffing models, which leaves emergency physicians looking for something else. So I mean, who knows what the crystal ball, no one has a crystal ball, but I anticipate that we're probably also going to see a fair number of emergency physicians who have been practicing for a while go back and do a fellowship as well. I don't know. We'll see where it goes. But I would agree that if you don't like critical care, if you don't want to work in the ICU, you shouldn't do a critical care fellowship. You do the fellowship to work in the ICU.
Yeah, I would agree. You certainly don't need a fellowship to be a fantastic emergency physician. And I think the job market's going to get harder, but in EM in general, I think it was so good for so many years that yeah, things will probably not be as easy. But if you're a good emergency physician, you're a good resident, you're going to get a job through networking, through your reputation. You'll find a job. I wouldn't do a fellowship just to get a job. But what I like about what I do is it gives me two options, right? If I want to work in a certain geographical area, I have two options now. I could work as a full-time intensivist or a full-time emergency physician if I had to. It may not be ideal for me, but if I needed to be in a certain area, then I have different options. And I like being the expert in my group too. I enjoy that. If I'm part of a conference and a critical care topic comes up, I get asked questions, and I think that's a lot of fun. But of course, you could be the expert on ultrasound. You could be the expert on sports medicine. You could be do any of the other fellowships that are out there too. But I think there's many great options. I think it makes you more competitive, but it's certainly not necessary to be a really good emergency physician.
Some great responses. And Dr. Emlet, yeah, the EMIM critical care pathway, I took that as a free rein to tell my wife that I'm okay to do another fellowship. I'm just collecting board certifications until public service loan forgiveness. But another question, and something that I actually struggled with too, because in internal conflict of probably doing 8 years of residency is too much. Somebody asked from the registered attendees, what were your thoughts on taking time off before fellowship? So I imagine the assumption would be to work as an attending for a few years to collect a better salary and then to go back.
It depends on the program, and I think it also depends on what you intend to do at that time. If you're using it to, when you say time off, I'm assuming you're just working. If you're not really managing a lot of critically ill patients or having some kind of relationship with intensivists or doing some kind of quality improvement project related to ventilation in your hospital, I don't know. I guess it just is. I find it a little bit more challenging. We sometimes worry about the transition back from whether you're IM or EM to come back from being an attending into fellowship again. It's hard to unbreak and undo and recall and flex those muscles of what it's like to be PGY4 again, and having a lot of people tell you how they think this should be managed, and you pretty much are taking orders rather than you had free reign autonomy and was learning via system-based self-reflective practice on your own, right? So I think sometimes it's a harder, like the longer you go, the harder it is. I think for some people where it's very clear for visa issues or their partner needed to, kind of get things settled with their job, it was a 2-year hiatus or 1-year hiatus because of children, that's totally reasonable. But the longer it goes, it becomes a little interesting. I interview often out of curiosity just to see, because sometimes they have a lot of good hardworking ethic, especially depending what they put on their CV. So I think the hard thing is that it may be easier or harder for you to get things on your CV depending which job you take. So the only advice I would say is be cautious in what job you decide. Like, don't do a locums job. You have to do something where you're actually just building on your career, but just in a different way. Like you actually truly want to truly experiment with a pivot into the community because you want to try to see what it was like, and you got involved with healthcare administration and leadership, and you really loved it, and you did all your sepsis bundles, and it totally makes sense for you to do critical care fellowship. That's a good portfolio. If you sort of take a complete hiatus and you just went out to make some money for a little while, that's going to be a little bit harder. Again, unless there were extenuating personal circumstances like death, birth, illness, those types of things.
Well, I just want to say thank you so much to our panelists. We are exceedingly lucky. And I hope just the array of people and their backgrounds and their insight is enough to convince you all to go into critical care, because everyone in EM critical care is wonderful. And again, thank you. You can always reach out to us and come to our critical care medicine section meetings. We're happy to have you, and let us know if you have any questions, and sign up to be a mentee and do other stuff with us. Anyone have any other parting thoughts, things we missed? Thank you, Fred, for moderating with me. I'm so lucky. And just thank you, everyone.
So the meetings are every first Thursday of the month. So you know when the next meeting is. It's every first Thursday.
And always a plug for EMIM critical care.